Great. Well, Bonnie and I are very appreciative that we could do a little ASCRS symposium, and hope you'll come to one of our meetings. They're usually in April. Be sure to come in 2 years because Bonnie will be our new president in 2 years. And one of the things that she and I have worked on is it's called the FACO Fundamentals Classroom. So this is a free online classroom that anyone around the world can register for. You go to our website, or I think it says there in the blue at the bottom, faco.ascrs.org. And what we've tried to do is put together lectures, some articles, there's a textbook there, and these are resources from residency on up that review really the fundamentals of FACO. And unlike YouTube, this has all gone through an editorial board that Bonnie and I are on, so we hope you'll at least learn from a distance from Ascaris. All right, let's see, my next slide. So I'm going to try to talk about complications of advanced technology IOLs. What do we do when things don't go well? So the first topic is PC rupture. Don't really have any financial interest in any of the instruments or the devices that I'll show. So can we turn the lights down? So here's a problem. This 34-year-old has a toric in the other eye, and I have a posterior capsule tear. 34 years old. She is going to go through the rest of her life unhappy that we didn't put in a toric in this eye, although we could do LASIK, of course. But what can we do in this situation? Well, this is the stellate tear there, so I'm grabbing it with these MST capsule forceps, the advantage being they can go through a limbal incision. And what if I can just round that tear off? Now, the problem with a posterior capsule is, it's very thin. So it's like a pediatric anterior capsule. So I have to use Brian Little's capsule tear-out rescue maneuver where I pull in a way that I keep the tear, the flap on a lot of traction. But by doing that, I think I've actually rounded it off. And because I don't have a stellate edge now, I can go in and do a vitrectomy. It doesn't expand. And here I'm going to go ahead and try to inflate the space in between the anterior and the posterior capsule. So I have an anterior and a posterior curvilinear tear or opening. So the problem then is trying to get this in between, but luckily with the single-piece Acrosoft platform, it opens up slowly, and so first one and then the other. So if I can get this in, the problem with a toric is you always have to rotate it. So an anterior capsule tear, single-piece acrylic is easy to put in, but what if you have to rotate it? And that's the advantage of the posterior capsulorhexis here is to be able to rotate it. So now we've got it in that plane, but watch, we have to rotate it. And this is where you get into trouble if you don't have a continuous edge. And I will, although so there you see it lined up. And, for a young person, I think it's actually okay, even if you're not sure if it's going to be aligned, to give it a try because she's 34, you're never going to have another chance to do it. And the worst thing is you can explant it and put in a single piece. Now, here's another young lady, 56, and I am really sweating right now. Why? She is my biggest fan. She has told all of her friends how great I am because after the restore in her first eye, she's 20/20 J1. This is her second eye, and on the nasal side, I have a big tear in the posterior capsule, and I'm not going to be able to round this off. So what am I going to do now? I'm just thinking as I get the cortex out here, I'm in trouble. So restore in the other eye, she just is so excited about that. And you know what? I don't have a 3-piece restore in my OR. We just don't carry those. We don't need those. So what the heck am I going to do here? I guess I could put it on monofocal and sort of break the news to her. But there is another technique, and it's called reverse optic capture. And it's a great technique to know about. And, again, will it work here? I don't know. First of all, I'm going to fill the chamber, so when I come out, I don't shallow and have vitreous prolapsing in. The rexus looks pretty centered, So let's give it a try. Because again, what's the worst thing that could happen? It could be tilted, decentered. I can take the lens out and put in the monofocal then. But if she's ever gonna have a chance at a multifocal, it's gonna be now. So what do? You put this through the capsulorhexis, but there's no posterior capsule on the nasal side now. So how are we going to keep this lens from not tilting or from rotating? So you've got to have the haptics under the anterior capsule, and I'm going to pop the optic up through the capsulorhexis. It's reverse optic capture. So how is that going to happen? You need two hooks. So one goes underneath, and so here you see on the temporal side where I'm sitting, that optic is coming forward, and then I'm going to try to get the other side to pull the optic forward. So picture this now, the optic is in front of the capsulorhexis. The optic is actually in the sulcus, but the haptics are underneath the capsulorhexis. And that's important because we all know that the thick, sharp edge of those haptics is what causes the iris chafe and the pigment dispersion syndrome. So now I'm having to sort of make sure the optic is in front of the edge, keeps it from dropping back, keeps it from tilting, keeps it from rotating. And we've all done the three-piece capture with the reverse, right? We push the optic through the rhexis, and then you see an elliptical shape to your capsulorhexis. This will become actually a sort of a rectangular shape here. So I'll outline that with some arrows. There's the posterior capsule tear, and you see how the anterior capsule is a little bit rectangular because of the broad junction of the haptic with the optic. And thank goodness she did well. Now here's another problem. I put in this toric, everything was going great, and then I realized somehow I tore the capsule on the nasal side when I injected the toric lens. Probably not enough viscoelastic. Now what? I got a toric IOL in the eye with a hole in the nasal capsule. Again, no chance to do a posterior capsulorhexis. What am I going to do? Well, you see where the mark is. It's the one to your right. That's the probably the 165 axis that I want. But what if I can pop the optic through, reverse optic capture, so that this lens will not only be prevented from tipping backward, but it will also not rotate. Very important with the toric. Now this rhexis, what do you notice? It's a little bit larger. So I have to, worry about, do I have enough anterior capsule underneath the optic to capture it? It's a little easier to capture, but there it is. We're actually pulling it up. So you have to use, the two hooks. It's kind of like chopsticks. One time it's an advantage to be Asian. And I'm lifting with one. And here I'm actually just dilated into location, so it's lined up with the toric mark. So this is something that is a good trick to have in your toolbox, because again, normally with a intact rhexis, you can just put a three-piece IOL in the sulcus, capture the optic the other way, haptics in front of the anterior capsule, you push the optic through. But when you have a refractive IOL, you got this single-piece acrylic platform, I think it's sometimes worth the try. So here again is the posterior capsule tear, and then I'll outline the anterior capsule edge, which is just behind the optic, so that the lens is in the sulcus. And fortunately, both of these patients, I was lucky, I got away with. So when can you do this? Well, you have this PC rupture with an intact rhexis. And this single-piece acrylic platform, the haptics are behind the rhexis, optic anterior. You can't really do this if the rhexis is decentered, if you have a large zonular dialysis, or the rhexis is too small or too large. The advantages, well, the optic now will block the vitreous from coming forward. The rhexis serves to center the optic if it is centered, and the anterior capsule does seem to prevent any chafing from the iris. And even though the optic is in front, it's so taut against the capsule, there seems to be enough clearance there. Others have talked about this. Gimbel first talked about this as a method of fixation after tear. Acacia in Brazil talked about, well, if you have a little bit of a hyperopic surprise, you can move it forward and it will induce some myopia. And then Maskett and Fram talked about this as a treatment for negative temporal dysphotopsia. What about the refractive adjustment? Will the optic rub against the iris? You certainly do get some fibrotic PCO because you don't have the optic separating the anterior and the posterior capsule. There's really only one paper in the literature that I was able to find from Jones and Oeding. It's kind of a neat paper because they had 16 eyes that they did reverse optic capture with, and 12 of the cases had a fellow eye with the lens in the bag that they used as a control. Good follow-up. This just shows everybody got good BCVA within plus or minus a diopter, yes, but look at this. With the reverse optic capture, 63% only were within a half diopter, and it was basically an average or a mean of a minus shift. So it does look like, particularly with a higher power lens, you have to subtract a half diopter if you have that opportunity. And this is one of many techniques that we talk about with posterior capsule rupture in my book. All right, so the last two topics that I'll try to cover are unhappy multifocal IOL patients and then the challenge of multifocal IOL exchange. So I have no financial interest in the instruments that you're going to see or in tracing. So when we evaluate premium IOL patients, we all know the importance of looking at the macula. In fact, we get 10 micron resolution with our spectral domain OCT. But I think our blind spot all too often is the optical quality of the cornea. I mean, we spend all this time working on the optics of the IOL. Doesn't it make sense the cornea is really important? So I've been using the Tracy for many years now. It serves as a topographer, as you see there, but it also measures the higher order aberrations. It'll show you that in the total eye, but of course that by itself doesn't help unless you can separate what's coming from the lens and what's coming from the cornea. And Bonnie showed you the Nidec OPD2, which does the same thing. These are the two machines that can separate high order aberrations just from the cornea versus the internal optics. And this is best illustrated by showing you some patients that I have seen. So here's a 71-year-old. He's 2 years post-restore. He's got a cataract in the left eye, and his big complaint is the anisometropia. Well, that's easy. You do the other eye. Well, why has he waited for 2 years, even though he's 20/20 uncorrected, and he's 2100 in the other eye? What is wrong here? He says the right eye is blurry. Well, this is his eye, and it looks like there's a tear in the posterior capsule. There you see it, and this haptic looks like it's in the sulcus. So I think he's got one in and one out. So this is looking at his higher order aberrations. In the phakic eye with the cataract, you see the simulated E, that's the point spread function. And look at the 20/20 restore eye. The point spread function is not very clear. So this is higher order aberrations. It means you've corrected the astigmatism in the sphere with glasses, and this is the BCVA. It's not very good. So this is the aberrations for the entire eye, and I tell the patient when we look at this, you don't want to see a lot of bars. It's like static in a headphone. That's not good visual quality or optical audio quality. But this upper left shows you the internal optics. This shows you the corneal optics, and you can see that there's a lot of higher order aberrations, and they're coming from the internal optics. It's not coming from the cornea. So you're going to say, well, of course, this is obvious. Multifocal lenses, there's this trade-off. You don't get good optical quality. So let me show you another restore. And you see it doesn't really register as higher order aberrations, total eye, or the optics here. So why do you think we've got higher order aberrations in this eye coming from the internal optics? Any thoughts? Anybody? Could it be that the lens is tilted and maybe that's creating the aberrations? I don't know. But one thing's for sure, this patient is 20/20, doesn't want to get the other eye done, and we're seeing actually objective signs that his visual quality is not very good. So what's the first thing you're going to do then? How many people would explant this lens? Remember, there's an open posterior capsule there, and he's 20/20 uncorrected, 20/20 BCVA. How many people would take this lens out? Few. What would the rest of you do? So, I said, how important is it to read without glasses? I'll wear glasses. I just can't wear glasses now. My eyes are too different. So I said, let's put a monofocal in your other eye. Let's put a toric lens in. And maybe, it won't bother you so much. We'll certainly treat the aniso. We're very lucky here. We got him to be plano. And I said, why don't you give it a couple months now, and maybe your night vision, it won't bother you so much that your right eye has this blur because you've got a good left eye. And he called back after a week and said, no way, get that lens out. There is so much difference. I don't want to live with this blur in my right eye. So we went ahead and exchanged the right eye. Well, we'll show that. So how do we exchange the lens? We've got an open capsule. We've got one haptic in the sulcus, one in the bag. How many years out? 2 years. So I'm just going to go ahead and I'm going to work temporally. And lots of dispersive viscoelastic here. This happens to be visco, but I'm going right over the open capsule. This is my barrier because there's the hyaloid face right underneath there. And so this is a difficult decision, right? You're taking a 20/20 eye and going in there, but that's why we did the other eye first. So that haptic on the temporal side is loose. It's in the sulcus. Here's the nasal haptic, and what's going to be the problem? There's a little terminal bulb, and it's going to be fibrosed in, and it's not going to come. And remember, I don't want to push too hard because I have an open hyaloid face. So this is the MST IOL cutter. And because it goes through a 1.2 millimeter incision, I can bring it in through a separate limbal clear corneal incision. I turn it to the side so I bevel the cut, and I pull on the haptic a little bit so that when I cut it, it retracts under the anterior capsule so that it isn't rubbing against the iris. And then again, lots more viscoelastic. Keep putting dispersive underneath there. Now that haptic is free, and then I dial it into the anterior chamber, where I can work on it a little bit further away from the capsule. Now, the normal way you would do this is you'd come in from the side with an IOL grasping forceps that you'll see here. Goes through a 1 millimeter incision even, and here's the cutter going through the incision. And you see that the blades open and close without gaping the incision, which would otherwise cause the OVD to leak out. So that's the benefit of this particular design. I'm going to now pull out first one piece, then the other, but not without replacing my dispersive. We use a dispersive because it doesn't come out easily. It likes to stay where you put it. We're going to leave some in there. It's a lower molecular weight, so we'll have less likelihood of a protracted IOP rise. We pull on this here, and voila, we're out. But remember, we cut one haptic, and there it is. It's underneath the anterior capsule, and fortunately, doesn't look like we have vitreous. So what lens are we going to put in? Well, I think we're going to put in a 3-piece foldable monofocal in the sulcus. See, there's the wraparound tear, so we know where we have to keep our haptics away from. And one could put in any 3-piece and consider suturing it. This is just showing this is not a particularly large eye. And in the U.S., the longest of our foldable 3-pieces is the Star AQ 2010. It's a little bit difficult to inject, but it has these polyamide haptics. So I like to open it into the anterior chamber. So now we dial one haptic in, and remember, we want to avoid right where the shaft of my Lester hook is where the other tear, the wraparound tear is. So I have to dial it in a way that it doesn't push against that tear. And there we are, and we're going to leave it right there. And because of the 13.5 millimeter length, it's a little bit longer. It's going to center well. We look over there, and there's the haptic. And it's definitely, I'm just checking here to make sure it's lying on top of the capsule. So we've succeeded, fortunately, without having to do a vitrectomy, although to have done a vitrectomy is still certainly not the end of the world to get the lens exchanged. All right, so we did this is showing him with the right eye monofocal. Fortunately, the power came out. He still had that cylinder, as you recall. And so he was happy. But the beauty of the Tracy here is we get an objective measurement of the optics of his eye without his subjective complaint. So this is with the Restore on the left. You see the point spread function down below. And here it is with the monofocal. See how much clearer it is? So there's actually an objective measure there. This is the full with a 5 millimeter pupil with the Restore, and this is with a monofocal. A little bit of aberrations, but a whole lot less, as you can see there. All right, let's do quickly another case. This is a 55-year-old chiropractor. He's 18 months after a resume, and he says, I know they said be patient. I'm going to get used to the halos and everything, but I don't think it's gotten better one bit after 18 months. Very intelligent patient. But he's 20/20 and J2 uncorrected. He's perfect. I mean, this is your nightmare. You did perfect surgery in a multifocal lens patient, and he's unhappy. He cannot adapt. He's gone on the internet where they have these things, show your doctor what you're seeing. And he's outlined in the upper right, this is what my vision is like. He's having ghosting. Wow. All right. Well, let's do the eye trace on him. So look at this, no cylinder, that's a SIM-K, and he has higher order aberrations with his 4.6 pupil, and it's from the cornea. So the cornea doesn't look too bad, but you see how there's a different height right in the middle, and that will frequently give you some coma. Look at the point spread function, the lower right there, it's all blurry. This is a 20/20 eye with poor optical quality, and the eye trace is giving me an objective measure of that. So I tell the patient, there's something wrong here, and it's probably your cornea. And it would be, it's hard to know this, but I think your cornea is a poor match for a multifocal. And first of all, he is so happy. He's actually happy because I'm telling him that he's not abnormal, that he's not imagining that there's a problem. I'm telling him there's really a problem. And what do you want to do? Well, we went ahead and we took out the lens. So just another case, and I think all too often we get in the situation where we put it in, you got it, after 4 months have gone by, we're not going to take it out, it's too risky, and we ask people to live with it. We say, you're going to get used to it. But I think we really need to think about multifocals as a reversible procedure. You have to be comfortable with explanting them, or alternatively, refer to someone who is, because there's absolutely no reason why after trying it, people try contact lenses, they try monovision, they try bifocal contacts. Some like them, some don't. If they don't, you take it out. And I don't think that we need to be, we shouldn't be too stubborn about offering IOL exchange when it's a multifocal, because again, the optical quality in some people is just not going to be good. Here you see the strategy, right? Open the bag up, go in multiple quadrants to do that. You have to be careful not to overinflate the eye. So sometimes you have to burp some out through the incision so you can keep injecting more in, and you're trying to reinflate the bag. How long? This is 18 months. But once we get it out, bring it in the anterior chamber. And there are a lot of different systems. This MST one is just one of them. But I think the key part here is they're using a second instrument to stabilize this. This is acrylic. The Resume is the AMO acrylic. Look how stiff it is. But the jaws of this cutter go right through it. But because I'm stabilizing the optic with the second instrument, it's not wobbling, it's not tilting, it's not running around the anterior chamber, because we all know these patients they've paid already for their lens extra, they're unhappy. The last thing we want to do is cut the rexus, cut the iris, or tear the posterior capsule. So we pull this out, and we put in here we have a nice intact bag. We just put in a monofocal in its place. I won't show that. Well, here is his pre-op with the Resume. And remember, the lower left, you see the aberrations from the cornea. So what is he going to look like post-op? Still has the aberrations from the cornea. We didn't do anything for the cornea. He was happy. First day post-op, he says, I know it's blurry from the surgery, but I can tell already it's much better. And so he was extremely happy to have that out. Okay, third case, unhappy restore patient. 57, she had LASIK, myopic LASIK 10 years ago. She's 4 months out after the restore, and it's just not clear. Well, no wonder. She's got cylinder in her left eye. She's 2100, but she corrects to 20/20 minus, and it was recommended that she simply needed a LASIK enhancement for that diopter cylinder. She's not so sure. So what can you do when everything else is normal? What would the first thing you should do? What would you do first? Well, you try to correct the cylinder, or you try to correct the refractive error. So we put a soft contact lens on. It's slightly sharper, but still not that clear. Not sure what she went through. Here's the lens. If you look out over to the left, it looks like there's actually maybe a tear in the anterior capsule there, but otherwise it looks centered. So do we take it out, or do we do a laser vision enhancement? Well, let's look at the tracy. And again, this is correcting. This is higher order aberrations, means you've already given them glasses for their cylinder, and this is the quality of vision left eye in the far right. It's not very good. So she's got poor optics in her eye. Well, this is her right eye, which has not had any surgery. There's the topography, and here's her left. And you see the topography is a little asymmetric, but being young, she has a large pupil. This is an undilated pupil, and she's got a lot of aberrations. Not a good candidate for a restore in retrospect, and she's unhappy. So again, you have the conversation. I think I know what the problem is. Your cornea is a little irregular, and that's just not a good match with a multifocal. You got to try it, but do you want me to take it out? And here we are taking this out. So again, I think that have this discussion fairly early. You have to, make that decision early on. Give people the glasses, a contact, do whatever you need to really test out, is this the problem? And all too often, we say, oh, there's a little wrinkle in the posterior capsule, maybe a YAG capsule. A lot of me will do it, and I think you have to be very careful there. Because, I myself wonder, gee, I have so many happy patients after multifocals, or some of my happiest patients. I wonder if I'd like to have one. And but you just don't know if you're going to have clear vision. Maybe it's angle kappa, maybe it's aberrations. It's kind of a big mystery as to why some people are so unhappy. But I think if you go into this thinking, okay, I can do an IOL exchange, I'm not sort of painted into a corner. This is Bonnie Henderson's method for taking it out without folding the lens. And so I'm reaching in, I'm going to get a good bite with a 0.12, and then I'm pushing on the other end with my Lester hook. And because this is at body temperature, it's a soft acrylic, and it molds against the incision, and it comes right out. So this is without having to fold it, and then we'll put this Technis monofocal in there. So here's the restore. This is that same patient. Corneal aberrations are going to still be there, aren't they? There they are. But this is with the monofocal. So the aberrations are a little bit less. I can do this comparison. So on the top is with the restore. On the bottom is the monofocal. Remember, she has corneal aberrations from her LASIK, but she's happy. Here's the simulated point spread function. It's not perfect, but it's better. Very happy patient. Very, very grateful that we took the lens out. Final case. Unhappy hypero who had a refractive lens exchange with the restore in the right eye. So she's 20/25 J8, but with correction she gets to J3. 2 months, and she's scared. She wants the other eye done. She can't stand the imbalance. So I said, what's keeping you? She said, look, she's still working at 68. She says, if my left eye sees as badly as my right eye, I'm going to have to retire. Whoa. So quality of vision not good in the right eye. What's going on? Well, this is the first thing you want to do, right? Remember I said before, let me show you a restore that doesn't have aberrations. That was actually her right eye. I'll show it to you again. Looks fine. So it's not an optical problem. What's going on here? That's her left eye, has the cataract. Well, I went ahead, it's not optics, so I did a 4-prism base out test, and she is a left eye monofixator. So as a lot of hyperopes are, there may be a little bit of accommodative esotropia. She has a small angle ESO. She's a left monofixator. Someone implanted a restore in her slightly amblyopic eye. And so that was the solution, that was the diagnosis, explained, let's do a monofocal in your other eye. I actually sent her back to Southern California to have that done, and that's what was done. So, conclusion, you have seen 3 cases, 1 where the IOL was tilted, 2 where a multifocal was added to people that had corneal aberrations, and the end result was poor optical quality. The patients presented subjectively saying there's something not right. But the Snellen was 20/20 every time. The exam was normal, and so, we say, hey, everything is normal, don't worry. And we think to ourselves, this is a really fussy patient. How come I always get the fussy patients? And what do we recommend? Give it time, you'll get used to it. Laser vision enhancement or a YAG capsulotomy. So that's why the benefit of this aberrometer, it's giving us objective correlation that something objectively is going wrong with their optical quality. And it teaches us a lot. So I use, as Bonnie just said, I look at those corneal aberrations in everybody, but particularly if I'm going to consider a multifocal. Certainly prior refractive corneas, you have to look at that. I really think now about IOL tilt from that one case. So if there's a torn rexus, weak zonules, not so sure a multifocal is a good idea. Very unforgiving of tilt or decentration. And likewise, that's why I'm a little worried about putting it in the sulcus. Now, I did show you a case of reverse optic capture. She had it in the other eye. But again, I think what helped me in that case is really, what's the worst thing that happens? It doesn't work, and you take it out and you put a monofocal in later. So that was the final lesson, is think of this as a reversible procedure, not something where we have to force the patient to adapt. Thank you very much.